Wonderful. I'll go ahead and start showing our slides so you know that you're in the right place. Welcome, welcome, everyone. All right. So you should be seeing my screen. And I'm going to go ahead and get us started. Thank you all for being here. It is exciting to have our social medicine round. It's always fun to come together as a community. We specifically do it in this virtual format so that we can have community members join us as well. And it is a pleasure, I think, to get to have the mix of people who come on board. So to get us started, I want to remind people who are new to this space what social medicine rounds are kind of meant for. It's an opportunity to connect with our staff, faculty, trainees, and community members and leaders to really talk about the different issues that affect the health of our Bronx community. And often these issues are reflective of the larger conversations that happen as well nationally, regionally, and nationally. So we have a series of rounds that we've been doing since 2021 that you're welcome to go back to and kind of take a look at and learn from. We are happy to send along anything that you need in terms of materials or recordings of that. And what we're going to do today is have a conversation with our speakers. One of our speakers is having a bit of a hard time joining on, so I apologize if you hear me in the background doing some of that troubleshooting, but we have another one of our esteemed speakers here. And so I'm excited for our own Dr. Selwyn to do an introduction for the speakers.
Hi, thanks, Stella. It's great to be here. Welcome, everybody. Welcome, speakers. So just very briefly, I have not had the pleasure of meeting Dr. Manchanda. I do know Jason Caraballo from the years he worked at Montefiore, but I'll introduce them both briefly. Dr. Rishi Manchanda is the founder and now CEO of a technology consulting firm in California, which really has a national scope that works with community organizations, healthcare systems, healthcare delivery entities to both improve care as well as address issues of structural health determinants of health and health equity through looking at systems and practice change. Before that, Dr. Manchanda was the chief medical officer of a company that addressed health and wellness and healthcare delivery needs for a large population of people in Central Valley, California. And prior to that, had worked as a primary care physician in Los Angeles, both in the VA system and the private sector, helping both to address needs of special populations as well as promote health equity and access to care. He received his all of his degrees, at least that I can tell, bachelor's, master's, and master's in public health and MD from Tufts, and did his residency in a combined medicine pediatric program at UCLA. So it's a pleasure to introduce Dr. Manchanda to these rounds. And Stella, should I just say a word about Jason, or should we wait until?
No, please go. He's on.
Oh, great. Wonderful. Hi, Jason. So Jason Caraballo is currently Director of Community Engagement for the Bronx for the Department of Health and Public Hygiene in New York. And prior to that, worked for a number of years at Montefiore as a community relations manager, involved both in addressing sort of the interface between patients and communities and the medical center, as well as promoting community health in a number of different ways, including being an important part of the institutional COVID response in the early phase of the COVID epidemic, as well as a number of other activities with different community stakeholders and organizations. Jason got his bachelor's from Georgetown and his master's in public administration from the Wagner School at NYU. So Jason, it's a pleasure to see you and welcome you back.
Thanks, wonderful. Thank you so much, Dr. Selwyn. Appreciate it. And thank you to our speakers, Dr. Manchanda and Mr. Caraballo. It's wonderful to have y'all. I just want to make sure that Jason is able to just do a quick audio check before we start. It looks like you're joining from two computers. Jason, can you just check in if you can, just to make sure you have your audio?
Can you hear me? Testing?
We can hear you. Yes, we can hear you. Perfect. Wonderful. So just to kind of orient us as to this conversation that we're having, many of us hear about swim in, live in, imagine these, 4 words, social determinants of health. And it has become a real phrase that is utilized in different settings, sometimes accurately, sometimes not. And it felt like a good time as we're thinking about the changes that are happening in the political and kind of socioeconomic climate to come back to think about what this means. And as Dr. Sullivan has introduced, Dr. Manchanda is a national expert in talking about social determinants of health. And he's coined the term upstreamist that has kind of been popularized throughout the medical profession. And so we wanted him to kind of offer his thoughts on where we are now. It feels important, and the feedback that we get from you all in rounds, which I love because I love to be very tangible, is that it's great to talk about things at a high level, but many of us on the line are clinicians seeing patients. Many of us are community members. So there's always this question of like, and so what do we do with this? So Jason Caraballo joins us to talk to you specifically about how public health and our public health resources are delivering on addressing social determinants of health needs within the Bronx community. And so there is a high level comprehensive, this is what it is. And then there is like a deeper, let's dig in and really understand how this applies to you. And as always, we're going to be sharing resources in the chat. We welcome you to put questions in the chat and to come off when we have our discussion portion to ask questions directly. But with that, I'm going to go ahead and turn it over to Dr. Manchanda, please.
Stella, thank you so much. Let me go ahead and share my screen and launch in. And I think I have about 20 minutes. Is that right? Or any less than that? More? Okay. What I'm going to do is a bit of choose your own adventure type of thing. So I'm going to look for engagement from everybody in the chat if you're able, and if not, unmute, use emojis, whatever feels possible for you, to be able to give me a key point, sense of where you want to go, because there's a lot of potential rabbit holes that we can go down to understand a bit more about how to move upstream and what social determinants kind of means. And I'll make sure we have space for Jason to hear from you as well. So let me go ahead and share a screen here, and let me know if you can see my screen.
Yes, we can see it.
So thank you so much again for the opportunity, Stella, and to Peter and to everybody. It's really a pleasure to kind of join you guys, especially at this moment that we're facing right now, this inflection point as we see it in healthcare's journey upstream. We're filled with a lot of promise because of recent advances in healthcare equity and also the integration of health and social care, which is a frame I'll use to come back and talk about social needs and social determinants. But we also face some peril. There's some risks that we're facing right now. And I'll share a couple of examples of some tools that my colleagues and I use in our networks to be able to help healthcare move upstream in ways that align these different conversations that we seem to be having around health equity, healthcare equity, social determinants of health, structural determinants of health equity, health and human rights. There's a lot of different conversations that are happening here across all levels, and I'll show you ways in which we help facilitate conversations among frontline clinicians, practice leaders, system level kind of leaders in health systems, as well as in managed care plans to be able to move upstream. HealthBegins is just to kind of recap and maybe add some more color to what Peter, thankfully you mentioned. We're a national mission-driven firm. I founded it in 2012, but it's been full-time for the past 6 years now, actually. For myself and our team, we have 20 staff working across the country, but with a big presence in California. We help Medicaid-serving health plans, health systems that predominantly care for Medicaid enrollees or those eligible, as well as community-based organizations who want to advance their social mission by working with Medicaid. We help all three of those client segments to be able to exceed some of the emerging healthcare equity and social needs requirements that we're seeing, especially in Medicaid, but also to do so in a way to achieve, with a structural kind of analysis, a public health kind of frame, long-term impact for people and communities harmed by societal practices. We have a big goal to be able to help advance this work in 250 communities by 2025. In 2022, we made some progress towards that, so you can get a sense of the breadth of the work that we do in a number of states across the country, a number of leaders that we work with as clients, and a number of communities where we've helped design, implement strategies in support of those courageous leaders. There's a few things I wanted just to underscore here to orient you to the key observations that really inform our work, as well as our use of the upstream parable, which is familiar to all of you. One is the fact that in these discussions now more than ever, I'm talking about inequities or disparities, as some sometimes say. What is missing sometimes, more often than not, especially as it becomes now more crowded with a lot of professional approaches and regulations, is the fact that inequities are really experienced as harm. palpably, emotionally felt as harm by those who are most impacted, of course. And we need, especially in healthcare, especially in medicine, to be able to kind of bring the voice of what it means to bear witness to that harm as part of these, as more and more policy conversations center around health equity. I think we have a role to play to be able to make sure that people understand inequity not as some abstract population level kind of phenomenon, but really as harm. And it's important, therefore, to also bring, as I know all of you do in your work, the understanding that it's not individual behavior, but in fact, social arrangements, structural violence, right, that is putting people in harm's way. And that, of course, we're talking not about negative peace, but positive peace, not just the absence of inequities, but the presence of systems that promote and preserve healing and justice. And again, I'm hoping I'm speaking to people in the choir here. The other important thing, especially when we're thinking about bridge building, kind of repairing the divide that's occurred in the US because of many choices over many generations between healthcare and public health. I think part of our responsibility in healthcare, especially in social medicine, is to try to bridge now the industry, the experiences, the resources of healthcare to a public health agenda. And in part, that happens by understanding, of course, that structural harm, structural violence is spatialized, and therefore any healthcare system that hopes to be able to advance health equity must therefore develop first a portfolio of strategies, not just a patchwork of programs, but secondly, develop a place-based approach, one that is outcomes focused and that also works across levels. And I'll talk about that in a second. And finally, a lot of the work, the observation that continuously kind of sings at the heart of our work is the fact that we're talking about not just clients, but the people that we work with are people who are sometimes formally trained in social medicine, sometimes trained in medicine, sometimes not, but they're in positions of power. Sometimes just recently placed in those positions, sometimes hard-earned after many years. And those leaders who are often courageous, the ones that we prefer working with are the ones who are trying to be or already have demonstrated a degree of courage to be able to transform systems and not just implement programs. They need support. We all do. Support and solidarity in practice to implement these strategies, but to also receive the support and solidarity to transform our institutions, our relationships across institutions and within them, our communities, of course, and also ourselves in the process. This is where leadership and the kind of emotional, psychological journey of what it means to be an upstreamist kind of resonates. So first kind of question really for the group is, does this ring true? You can give me a +3 if it rings true, all the way to a -3 if this concerns or aggravates you. +3 if this so far resonates with you, because I want to know who I'm in the room with today. So I'll see if I can take a look at the chat, or maybe Stella, if you could voice over the range of responses. Does this resonate? I see some +3s there.
+3s, some +3s.
Great. All right.
To the choir. We're not the social medicine folks for no reason.
Exactly. Good. Well, that's what I was expecting, and that validates my assumptions here. I appreciate it. And so a couple of things just to illustrate. We in a lot of our work, we ground this in the story of patients today. In the short time that I have, I'm not going to go through our kind of case-based approach that we do to do a lot of our work, but just to illustrate that when we talk about getting proximate, as we all do in our work, and again, each of you, I think, in your work is proximate to the experience of inequities as harm. I think this affords us a rare opportunity and power to be able to help people understand that harm and also understand the social, institutional, and structural arrangements that put people in harm's way. A big part of what we do is also to help popularize this understanding of structural competency in ways that don't get lost in the academic jargon of it, because this is about movement building. This is not just about publishing right papers or convincing those of us who are maybe in our periphery of academic medicine. It's really about thinking about ways to talk to our patients about this work, and to our colleagues in the community and to others. And a big way we do this in our work, I want to share with you, because strategy and specific concrete tactics to be able to do this work rests fundamentally on story, the story that we tell ourselves. And so here's a way in which I'm sharing with you. I often kind of orient groups of people, including those of us who are in healthcare and sometimes those who are not in community or social sectors, to what structural competency can kind of feel like. You're all familiar with this, right? You didn't give a man a fish, you feed him for a day, teach a man a fish, and you feed him for a lifetime. This is such a widespread kind of proverb that many people don't remember when they first heard it, or know where to cite it or how to cite this work, because it's baked into the kind of the common the norms, the vernacular of what it means to be a human in American society right now. We're like, oh yes, this makes us give a man a fish, feed him for a day, teach a man a fish, feed him for a lifetime. As social medicine people, of course, we understand, and as people who think about structural kind of analysis, we also understand that there's an opportunity here to use common tropes, to use common kind of adages, right? To be able to help people to understand that a structural analysis teaches us to do a little bit something different. It teaches us to look at the structures and the systems behind this. And what I invite you to think about is an example I just shared over here is asking us, how do we popularize structural competency? How do we popularize social medicine concepts in ways that don't anchor to social medicine, right? That anchor to actually common stories and adages and proverbs. And this has been a lot of our work animated by the work we do as we get proximate to people in communities as well. And it's an exciting part, frankly, of social medicine. This is where folks like Jack Geiger and many others were role models for me as I learned how to popularize social medicine. The upstream parable is another example of that. I wrote a small book about this over 10 years ago, put a term out there called the upstreamist, because I was tired of talking about myself as a social medicine doc with other people, both within medicine and at the dinner table and in other communities, because I end up usually taking about 5 minutes to explain all the things I was passionate about, and realized, well, if I just say I'm an upstreamist, then I get the conversation going around, what does that mean? And then we can get into a conversation. So communications, framing, and storytelling is a huge part of our work, and I think part of our collective work as well. In terms of what we do besides storytelling, there's a lot of work we do in HealthBegins in terms of services, and I'm going to skip past this slide because of time, but there's a lot of animation here in terms of the work that we do across the country to be able to provide strategy consulting, design and scale big programs and initiatives, and drive equity-focused outcomes. But for today, I wanted to just underscore a couple of quick points. We are at this inflection point, and I'll go through that really quickly so I can walk you through a couple of frameworks that we use. This is just a couple of things I thought I'd kind of highlight that might be useful given what Stella charged me to do today. So the inflection point, this is the bottom line up front. We have come a long way in the last few years in centering equity and pursuing health and social care integration. There's been advances in systems and standards at the national level. There's been some policy advances as well. And there's been some notable innovation as well. We shouldn't forget that. And I think a big part of the story of us and the story of kind of mobilizing change in social medicine is that we sometimes, not maybe this group, but many groups that I sometimes join and even some clients and partners that we work with tend to focus on the peril and not the promise that's made. So we need to pause and acknowledge the advances that we've made so far, and I'll show you some examples of that. Because if we can't celebrate the successes, however incremental they've been, then we can't hope to continue the energy and the engagement that we need to continue to make the major kind of transformative changes we want. There's also a lot of peril, of course, in this moment, and including whitewashing and the fact that the health equity work, quote unquote, that's now centering in a lot of healthcare conversations might be actually might be in lip service and might end up perpetuating social arrangements that are putting people in harm's way. But that means we have an opportunity. So what I mean by advances, the promise of the past few years in particular, we've seen advances in healthcare equity standards. You see the acronyms here for some of the organizations, NCQA, CMS, the National Quality Forum, IHI. You see examples of ways in which social care standards, not just equity, are showing up in quality measures, regulations, standards, and models across a whole variety of stakeholders and accreditors and regulators in the healthcare landscape as well. This is worthy of celebration. There's quite a lot happening here. You see, and I'm happy to share these resources with you guys so you guys can look at this if this is of interest to anybody. We're seeing advances not just in how to screen for social needs, but also how to intervene on social needs in healthcare. And so the Gravity Project obviously has been a major touchstone for a lot of the development of national standards. We're seeing at the Medicaid level, especially where we work at HealthBegins, a lot of advances at the state level in strategies to focus on equity within healthcare, strategies to be able to move equity into Medicaid managed care organization contracts. That's what MCO stands for, managed care organizations. And so while there's still a lot of ways to go, we're seeing a lot of progress in the last few years around the inclusion of health equity requirements into state Medicaid contracts and reprocurement kind of cycles as well, big policy levers to be able to advance equity as well as social needs. So you see examples here of how states have also started to require managed care organizations to screen enrollees, and what they're requiring of managed care organizations, so the health plans, also then flows downstream to providers as well. And it's slow, but there is progress being made. We're seeing examples of how more and more people are talking about value, not just return on investment, but value of this work and starting to build partnerships. This is one resource that we put together a couple of years ago and still very actively used. One-stop shop for healthcare and community organizations that want to find ways to partner with each other to kind of be able to pursue that value together. And we're seeing evidence of impact. Commonwealth Fund put out this really great summary of impact across housing, food, transportation, a variety of different social needs domains. And you're seeing evidence now accumulate around which is essential, of course, to convince everybody in healthcare, including us in clinical medicine, to kind of do this work. And of course, we're seeing research now coming out, including in places like Massachusetts, where preliminary evidence shows that hospitals with more robust programs to do SDOH work, as they term it, there's associations of that investment with higher patient experience scores, and also, fascinatingly, with lower mortality rates for key cardiovascular conditions. So we're seeing these preliminary kind of things that give us a lot of hope. There's a lot of risk, however, in this moment. The risk, of course, is there's many different risks. Here's a summary of the high-level ones. I won't go into all of them today. Maybe I'll highlight a few of these. One of them is that we're just like with social determinants of health as a term, we in healthcare are starting to co-opt and abuse health equity as a term as well. What healthcare actually is doing is healthcare equity. Most of what's happening in healthcare is really about healthcare equity, which is a major, significant, but still and necessary, but still only one component of a broader kind of move to attain health equity. Health equity definitions abound. You may have your own definitions that you use, but health equity includes and requires us in healthcare to do our job. But healthcare equity itself, of course, is not sufficient to do everything that's required for healthcare equity, nor is it sufficient to fully now embed healthcare equity and health equity within the broader health human rights endeavors. The work that has been pioneered both internationally and in many communities around the US. There's work to be done to be able to define terms that are being used these days to define equity, to contextualize them more clearly, and to make sure that we don't end up contributing to the conflation, confusion, and the co-optation of equity efforts because of lack of discipline in this work. So healthcare equity, health equity, and health and human rights are conceptual domains that I think we're going to have to become more and more proficient in as social medicine kind of champions to be able to communicate to others, in my opinion. And that also then implicates SDOH. We have done a good job in misusing, misapplying SDOH in healthcare. As you may know, the World Health Organization in 2008, the Commission on Social Determinants of Health, put out a seminal report defining both SDOH, social determinants of health, and defining it really as a phenomenon that lives at the community level, if not more broadly, at the structural level. What we in healthcare have done is to actually use SDOH to define what really is better understood as social risk factors and social needs, individual level phenomenon. We individualize population level phenomenon in healthcare routinely, and that's been happening in SDOH, and it's been happening in health equity. And we need to make sure that we pause and let people know that that's dangerous. It obfuscates the opportunities to actually apply multi-level approaches to do this work. So when it comes to equity, how do we actually move away from SDOH, but instead start talking about how we can counteract the social arrangements, the structures that cause harm and inequities, including ways to address social risk factors, to lower and reduce them, to improve social determinants at a community level, and then to, of course, address the structural determinants. Again, perhaps to this audience, old hat, singing to the choir, but I can't tell you how often it's required for us at HealthBegins and our colleagues in our networks, our community of practice, to continually come back to this point. There's a real risk if we continue to talk about SDOH without getting more precise. So here's a framework. I think I have maybe 3 minutes left, 1 minute left. How am I doing on time?
Sure, okay, keep going.
All right, good. I talk fast. I was born in Queens, by the way, and so the New Yorker speed is coming out in me. Don't hold it against me.
We love it.
All right. So a couple thoughts. These are kind of promise and peril. I'm talking at a high level. Let's talk about some tools, not the only tools, but some tools that we use in talking with hospitals in particular, and sometimes with health plans too, about how to do this work. And often every part of our work is about, if it's a hospital engagement, we bring in community-based organizations as partners and people with lived experience who are in our networks to be able to help inform this. One framework, though, is to how do we recognize the fact that transformation needs to happen at different levels. And of course, as you'll all appreciate, the social ecologic model is one thing that we do a lot of work on that we adapt in HealthBegins to be able to help bring this to a healthcare audience that often is not well educated in public health principles, nor in things like the social ecological model, right? And so here's an example of one way that we've adapted the social ecologic model to enable and institutional action, right, in healthcare. The health equity transformation map that you see here is an example of how we engage hospitals, institutions, health systems in thinking about how to build their health equity investment portfolios. Not a patchwork of programs, but a portfolio of health equity investments. And I can talk more about that if that's of interest in the Q&A. And so we talk about the different aims that exist at each level, right? There are some people and right now who are courageous leaders, who are upstreamists perhaps, who are health equity champions perhaps, who are in social medicine kind of champions like you, who are saying right now in this moment, in this opportunity, I need to kind of focus in on improving the program and care delivery for particular populations of patients. And I have data kind of priorities here. I have integration kind of priorities. I have the need also to identify how our institution might be contributing to the harm as well. These aims are critically important. These are program and care delivery kind of aims. Those are distinct, however, they're related, but distinct from others who say, well, the same person might also say, I also may have aims to be able to create more just, effective, equitable institutions. I want my hospital to be transformed and not just the programs that I deliver. And so there's a variety of aims here. And there's also others who say, or maybe the same people again, who say, but I also have aims at the ecosystem level. I want to be able to help contribute to the building of or strengthening of an ecosystem of which our hospital is one part of. And there are many different specific kind of aims that come out here among the clients we work with. And last but not least, there are other opportunity moments that are emerging around structural transformation, right? How do we transform, how do we replace and counteract policies and structures that are causing ongoing harms? This is where eyes go pretty glassy sometimes in many of the places we work in at HealthBegins, not because of lack of desire in some cases, but because of lack of efficacy, structural competency and structural efficacy, right? Lack of experience. But the aim is still there in some cases. What we do with this transformation map is actually ask that question, like, what is your aim? Or what are your aims, plural? And this is a clarifying exercise often when we're talking with folks to understand the fact that some people have aims that live across all levels. And if we don't pause and clarify the aims, it'd be as ineffective or as wasteful as talking to a patient and saying, and not asking, what are your goals, right? It's like delivering a bit of knowledge, a bit of wisdom, a bit of expertise to a patient without asking them, what are your goals? It's a similar concept when we think about change management and transformation when it comes to working with courageous leaders. We have to ask what their aims are. And this process is actually a clarifying exercise. And so there's a whole toolkit and the whole approach that we built up around this that we've seen now develop really good and have some really great traction from health systems as well as to Medicaid managed care plans. That's one framework, the transformation map, to help align to clarify and align aims for transformation, recognizing that all of these aims are required to do this work, and also recognizing that in any given moment, each of us in our institutions should clarify individually and collectively where we want to lead, where we want to partner, and where we want to support. It's no longer a question of, is it my job or is it not my job? Is it in my lane or is it not in my lane? That binary is a false choice that actually undermines the kind of efficacy that we individually and collectively need to implement right here. Instead, we need to recognize, just as we do with team-based care, that everybody has a role to lead, partner, and support. Same thing with change management and transformation for health equity. All right, well, if you like that 4-level kind of framework, last but not least, I'll show you how we take that 4-level and then take it to another, add a dimension to it to be able to help create a strategic portfolio. The reason that we do this is because we recognize that far too many health systems, because of a lack of incentives, structures, history, and competency around structural kind of change and sociologic models and public health kind of framing of how to do this kind of work, end up creating a patchwork of programs. And that's actually injurious to the cause. It's also less effective when it comes to delivering outcomes. Instead, what we need is to kind of move from a patchwork of programs to developing a portfolio of strategies. And portfolio strategies can take place you can develop in a number of different ways. Here's one method that we use to be able to align investments and to create a portfolio. For example, we define a specific population first in a specific place. Let's say, for example, that at Monte, you have one priority population are diabetic adults. In diabetic adults, you identify that there is a racial inequity in outcomes or access or quality related to that population. and it's a racial inequity that you identify. It could also be an inequity based on sexual orientation or gender identity, for example. But let's say you identify that pattern of inequity, and then you identify potential social drivers of that, again, in conversation with experts, including patients, people lived experience. Let's say in this example that we identify that economic and food insecurity are drivers of this particular pattern based on some analysis we've done. And last but not least, we identify, again, place. This is, again, where health systems tend to fall short. We don't do a place-based analysis, a geospatial analysis of the patterns of inequity. Now, let's say that we've done that work. This is what we do with our clients and our partners. Having done that, then we say, now, what are some ways to be able to design investments at the program and care delivery level to be able to reduce that inequity? And then we say, well, what, and then some different examples. I'm showing you here just examples of what might show up in that exercise. And then we say, now let's actually bring in, again, partners from the community, including organizations that do work in the same place, who have experience dealing with the same kind of issues, economic and food insecurity. Let's talk with those partners around this particular set of issues in this place and identify what solutions exist at the structural level and map those out. And usually this is where healthcare, we tend to have limited experience, but this is exactly why I bring in partners to help fill in the gaps. And then we say, well, let's look at potential solutions internally within your system. What are some internal institutional practices or policies? And lastly, what are some ecosystem level kind of opportunities? And what comes together then is a potential portfolio of various interventions across levels of prevention as well as levels of intervention, levels of transformation. And what comes out of this then is a set of choices then about, which is what you do with any portfolio. Where are we going to go for early wins? Where are we going to invest our time, resources, and energy? Where are we going to lead, partner, and support as healthcare and community partners? And then how are we going to reinvest some of the wins, some of the successes, including some of the value, the monetary value or the economic value that we generate because of these wins? How do we reinvest them more upstream? So the downstream left-hand side successes, right? Which is what we do in healthcare, where we lead to traditionally can be reinvested into efforts to support structural interventions. So I'll pause here or stop here because I think there's way too much other stuff. But see if those frameworks are a good enough kind of touchstone for conversation, and more importantly, to yield the floor to Jason. Thanks.
Thank you so much, Dr. Manchanda. I feel like it is exactly at the level that we wanted, which is extremely practical. And I really appreciate those frameworks. I think to go one layer even deeper and think about the Bronx context, we have our Bronx native, Jason Caraballo, who's going to present. And if there's any issues with your slides, Jason, I have them teed up. You're just on mute. Awesome.
Okay, now I'm going to share my screen. There we go. Can we all see my screen?
Yes, we can.
Okay, great. So first of all, thank you, Dr. Sappho, for inviting me and the Bureau of Bronx Neighborhood Health to share some information with all of you. Thank you, Dr. Selwyn, for the introduction. It's a pleasure to reconnect. I always enjoyed working with Dr. Selwyn, however I could when I was at Montefiore previously, and this is a little bit of a homecoming for me, so it's nice to be back. And excuse the background noise, somebody just entered my office and immediately exited. And Dr. Manchanda, thank you for your words and your presentation. Certainly set the stage for some of the more specific things that I'm going to be sharing with folks here today about how we do some of this work in the Bronx. And also, you know, a lot of what you shared is going to cause me to reassess a lot of what we do. So thank you for that, for sure. So first and foremost, give you a quick introduction of who we are. Some of you, depending on how long you've been in the Bronx, might know us by any of the following names, and it can get a little bit confusing out in the community. We were originally the Bronx District Public Health Office. And then the building that we operate out of is the Tremont Health Action Center. At some point, that became known as the Bronx Neighborhood Health Action Center. But our bureau is, of course, the Bureau of Bronx Neighborhood Health. And we sit within a larger division in the agency called the Center for Health Equity and Community Wellness. And that's who we are generally, just kind of as an organization, as an entity here in the community, but who we are specifically as the individuals who are working here and engaging with the community and delivering services and sharing information. I'm proud to say that most of us here are Bronxites. It's not necessarily a requirement that you be from the Bronx or live in the Bronx to work here. But thankfully, many of the folks who work here and are doing this work, they call the Bronx home, and they have a deep connection to the community. And we're able to reach the community best because we're from the community. So what do we do? So I mentioned, that we sit within the larger division called the Center for Health Equity and Community Wellness. And the division is largely charged with, of course, addressing health disparities within particular neighborhoods in the Bronx. These neighborhoods are identified as, they're highly segregated, of course, racially and based on poverty and high disease burden. We're the Bronx, the Bureau of Bronx Neighborhood Health, but we have two sister bureaus in other strategically located neighborhoods, one in Harlem and one in Brooklyn. So you see the Bronx neighborhood catchment area is highlighted in blue. We cover 6 community districts in the South Bronx that are roughly from around the Cross Bronx and below. And then, our sister bureaus in Harlem and Brooklyn, they do a lot of similar work we do with similarly challenged communities, and really take a place-based approach to try to address the needs of the residents of those communities. And we do so by providing services directly or just offering education, disseminating information, connecting people to resources. And some of the more specific things that we do, particularly out of our office here in the Bronx, is, a number of different programs and that I think, as I was listening to you, Dr. Manchanda, in some ways could probably be perceived as a patchwork of programs. So it's kind of got me thinking about reassessing what we do and how we do it. But some of our current efforts are intended to address a lot of the issues that we see here in the community where we're located. So, for example, one is a diabetes self-management education program. We're currently building out a much larger portfolio of diabetes programming, some that address food insecurity, some that provide some nutrition education. But this initial program is a 5-week program. We run several cohorts throughout the course of the year where folks who are pre-diabetic or diabetic learn some self-management techniques and come out of it very well informed and able to care for themselves better. We have a family wellness suite, which really drives a lot of traffic here to support families, expecting mothers, new parents, and support them in a wide variety of ways, from lactation education to parenting courses to providing eligible families with free car seats, free pack and play cribs, education on how to properly utilize those car seats and install them, and making sure that the baby is safe when in a vehicle. 2 of the community districts that we serve here in the Bronx, community districts 3 and 6, are actually 2 of the top 3 community districts across all of New York City when it comes to tobacco usage rates. So we offer a nicotine replacement therapy program to help people who are looking to change their habits when it comes to smoking or vaping. And of course, it goes without saying that all of the programs that we offer folks are at absolutely no cost to them. And we try to facilitate, if there's anything that we don't provide directly, we try to facilitate connections to other services available in the community that are equally no cost or low cost for beneficiaries. And then we also acknowledge that, there are a number of environmental factors that, of course, contribute to poor health outcomes for members of the community. Some of those environmental factors are within the home. Some exist outside of the home. To address some of the home factors, we recognize that, household pests can often be a trigger for folks who are living with asthma. And unfortunately, the housing stock in the Bronx is often aging, not always well maintained. And many housing units in the Bronx suffer with pest control issues. So that unfortunately contributes to a lot of avoidable asthma hospitalizations, particularly for young children. So we have a free integrated pest management program service for families with children under the age of 18 who reside in a home that has a pest issue. A thorough evaluation of the household environment is conducted by some vendors that we contract with. They do a full abatement of whatever the issues are that are contributing to the pest issue, and then also educate the family on how to continue to keep their homes pest-free, all with the ultimate goal of reducing avoidable asthma hospitalizations. And then addressing, being cognizant of some of those broader environmental factors that contribute to folks' health is, of course, the reimagining the Cross Bronx Expressway effort. I'm sure several of you folks here are at least superficially aware of the studies that are currently underway to reimagine the Cross Bronx Expressway and try to undo many of the harms that have been inflicted upon adjacent communities over the last 50 years since the expressway's construction. A lot of work to be done in that regard, and much of it is being community led, including by, I don't know if he's present on this Grand Rounds right now, Alex Levine from Einstein. There's been a huge community effort to draw attention to the ills that have been caused by the Cross Bronx Expressway. And that really got the attention of some people in charge. The feds have dedicated a good chunk of money to conduct some studies over the next couple of years on what can be done to address some of the health issues, or not just health issues, just overall community issues that the Cross Bronx Expressway has created over the years. This effort is led, of course, by community, but also City Department of City Planning, City Department of Transportation, as well as State Department of Transportation. And given the numerous health considerations related to this effort, the Department of Health is also playing a supportive role in this. We're working closely with the community to engage them and understand exactly what their issues are, what their concerns are, so that way this can all be considered in whatever plan is eventually proposed to help redesign the Cross Bronx Expressway and heal the communities that it's harmed. And also, we help facilitate the hashtag Not62 coalition. I'm sure folks here are probably aware of the Robert Wood Johnson Foundation's County Health Ranking Survey that's been conducted over the last, I think, maybe 11, 12 years. And in each of those years, out of the 62 counties in New York State, Bronx County has consistently ranked dead last in terms of health outcomes. So this is a coalition of various partners, clinical partners, including Montefiore, governmental partners, community-based partners, all of whom have a stake in the community, a stake in the community's health, and coming up with strategies both on a ground level as well as on a legislative level to try to ensure that the Bronx is no longer dead last when it comes to health outcomes, and that residents of the Bronx can continue to thrive healthily. So why do we do what we do? Well, first of all, it's necessary. We all know that health disparities have persisted in the Bronx for far too long. And these are the result of decades of disinvestment, negligence, various policies that have worked against communities of color, particularly Black and Latino communities, for far too long. And it requires attention. But of course, I'm preaching to the choir. Everyone here knows this. That's the reason everyone does the work that they do. And also right now, coming out of the pandemic, or maybe still in the midst of the pandemic, the general public has a greater awareness of public health now more than ever. Whether it's because they acknowledge how their health is directly impacted by factors, external factors around them, or how their own health impacts the health of others, or even some folks who might be on the opposite side of the coin and want to challenge some of that. Everybody is at least aware of public health. So now it's really a crucial time for us to jump on that awareness, make sure folks are properly educated and sufficiently informed to make whatever the best choices are for them, their families, and their communities. So how do we do it? everything we do is in partnership with others. We absolutely cannot accomplish what we do with the limited resources we have. And we rely on relationships with community-based organizations, faith-based organizations, clinical partners, schools, tenant groups, a bunch of folks who are out in the community. We rely on our relationships with them to reach people where they are, give us some credibility in the eyes of the people that we want to reach, because unfortunately, and not without reason, there's often distrust of governmental entities out in these communities, because much of the ills that these communities suffer are the direct result of government action or inaction in the past. And in order for us to try to reverse that, we really, really rely very heavily on partnerships with folks who are credible messengers in the community. And with those partners, we work very hard to build their capacity to promote health in the community, whether it's training their staff to carry out certain health promoting activities, whether it's assisting community partners in obtaining funds for whatever it is that they wish to do. If their mission is aligned with what we're trying to accomplish as an agency, then we lend whatever support we can to help them move in the direction that they're moving in, with the ultimate goal of course, promoting health equity in the community. And if you ever want to engage with us and partner with us on anything that you may already have going on within your department, if you want to support some of the work that we have going on and amplify our message, please feel free to contact us. I've listed our URL here, which is way too long for anyone to try to jot down. So just simply Google Tremont Health Action Center. That's what I do whenever I want to try to find our website. We're located at 1826 Arthur Avenue in the Tremont neighborhood. So I'm sure most folks are familiar with Arthur Avenue and the delicious Italian restaurants all up and down that corridor. We're not on that part of Arthur Avenue. We're a little bit further south by the Cross Bronx. And my email address is listed there below for anyone who wishes to contact me directly. So thank you all.
Thank you so much,
any
Jason.
questions.
Thank you so much. The floor is open for those who want to ask any questions. I'm going to begin with just some very quick practical questions. One for you, Rishi, is if a health system leader or leaders who are maybe on the line or hearing this looked at your framework for the kind of 3-level engagement across the multiple levels of inequities that you can have and said, how can we do this? But had to convince their board that this is important, what would you tell them to kind of talk about? Like what are kind of we know why this is important, but speaking that language of healthcare, what would you use to kind of argue for that? And then a kind of second question for Jason is, for our trainees that are listening that are thinking these resources are great, can you just say a little bit more about how to get involved and how they can either refer patients over to you or engage directly with you like Alex and others to really move some of the advocacy work forward, particularly around, the clean air campaigns that you all have. So Rishi, for you, what should we arm our system leaders with so that they can get this work pushed forward and paid for and really focused on? And Jason, for you, just a practical, how do we bring people on board and engage? And then again, opening up to others, feel free to raise your hand and we'll come over to you. Rishi?
Thanks, Stella. Yeah, and Jason, just gratitude. I really, really enjoyed your presentation, so thank you. For those who want to kind of move upstream, advance equity, and especially use a kind of multi-level approach to transformation to do so and get the support they need, I would say first, identify the priorities that your system already has and ask leadership if they care about achieving those. Ask if they care, if they're interested in achieving them successfully, efficiently, and equitably, right? Ask them why they wouldn't want to apply a kind of a system level, systemic kind of approach to achieve a system level priority, assuming that they've identified health equity and or social determinants as a priority, rather than just a kind of a grab bag kind of approach. So in other words, if this is truly, if you made a commitment to advance health equity or racial justice in that kind of way, isn't a systemic kind of approach necessary to do that? And if not, why? In other words, what are your priorities? Would you like to achieve them effectively, successfully, and efficiently? Secondly, if health equity is a priority or social determinants of health is a priority, would you like to apply it systematically, or should we do it in a way that we've done in the past, which has been, as results show, kind of ineffective? And the third is use the data and stories of partners and of people that experience. So bring the data to be able to reveal the patterns, right? The inequities that you want to kind of prioritize, identify, use data to also show the social risk factors and the social determinants that are related to those issues, and make it compelling to say, well, this data tells us that we need to be able to address this at the individual program, system, ecosystem kind of level. And then if they say, well, are you talking about investing a lot of money in that way? We say the last thing is, well, we've already made investments. The question is, can we make investments, whether it's in a new chief health equity officer or a new kind of department, or investments in current staff like quality improvement staff or the adverse event reporting system, whatever your investments are, can we use those investments in a way that's aligned to achieve the impact we want, rather than just have it be somewhat isolated? So in other words, do you want to leverage your investments for real impact, or should we let them be squandered?
Love it. Thank you. Thank you. Jason?
Yep. So if folks want to engage with us in any way, or refer patients or clients to us who can benefit from any of our services, again, I encourage you to please just email me, and I will facilitate any connections on your behalf. And I'm typing my email address in the chat right now, and I will drop my cell phone number in there as well.
That is commitment to the cause. Thank you.
So please feel free to be in touch. We're always looking to connect with new partners however we can. As I stated before, our work is only as effective as our relationships with other partners in the community are. So please feel free to reach out for anything we can support with.
Awesome. Thank you. And there is a question. This is part of the reason why we do the rounds in this format, is that we get to talk with folks who are thinking about these questions in different spaces that maybe aren't resourced or don't have the political setup that a California or a New York has. From a John Davis, I'll go ahead and read your, let me give you a second. John, do you want to come off of mute and ask your question, or kind of paraphrase your question? Or if I don't hear you in a couple of moments, I'll go ahead and ask the question that you've written.
Yes, thank you very much. I've enjoyed taking part in this social medicine rounds. So we're in Appalachia. We're in South Central Ohio. We're rural. We're an hour south of Columbus, and this is for Rishi. I'm wondering if you have pearls of success for those projects that you've done in rural areas, specifically, not exclusively Appalachian, but I would just be interested to hear your thoughts.
Yeah, I think so. I think thanks, John, for the question. We do have experience working in rural and semi-urban communities, and as well, not just urban kind of communities. Oftentimes that's with both managed care plans that have brought us in to help them with their health equity strategies, as well as with health systems and community health centers as well. So we have some experience in working with CHCs too. I think one important element that two things that I think I'll just share briefly is I'm recalling a conversation we had in one of our accelerator programs where some community health centers came together from pretty rural parts of the country who were trying to accelerate their efforts to improve the collection of race, ethnicity, and language data, right, which is a key foundational element to, of course, identifying inequities and addressing them. And one of the things that both teams in this particular from rural communities kind of highlighted was the fact that every community, including rural communities, has a different census, a different kind of population base, and that when you're thinking about in healthcare, updating our systems to be able to account for racial, ethnic, and even linguistic diversity, there needs to be more support given to be able to identify how to get granular, not just to provide the regular kind of OMB style kind of categories, but to get really granular to be able to reflect oftentimes indigenous communities, right? And others, or immigrant populations, thinking of populations of refugees and others, there's a lot more diversity that we often than we often acknowledge, I think, or recognize in rural communities, and that's a big part of one thing that we emphasize in a lot of our work, which is to help communities, including rural communities, identify the diversity of populations that exist. The second quick point is that in analyzing the data and then, of course, aligning action in a place-based kind of way, the geographies, the geospatial analysis need to take into account, obviously, broader communities oftentimes than we tend to do in census tract-based kind of work in urban communities. And there's a different set of, there's an additional set of skills and expertise required for people who actually work in rural communities to be peer faculty to others in those communities. And so when it comes to the technical parts, as well as the strategic and the political parts, frankly. So yeah, that's some initial reflections from working in rural communities, and that's just tip of the iceberg. I don't know if that is what you're looking for, John, but thanks for the question.
Thank you. Thank you for your time.
Thank you, John. I would say, maybe our last question can be around thinking about this question of community and partners, right? And so for those of us who live in the Bronx, I live in Brooklyn, but those who live in the Bronx who are healthcare utilizers, who are curious about, so as kind of like the community or community partners or members, what advice would you give about being a part of this kind of health equity work? So in other words, how can you be a part of this conversation? Because sometimes it feels as though those who are CBOs or service organizations are maybe engaged, and those who are maybe in like specific patient advocacy groups may be engaged, certainly clinicians and health systems. But if you're someone who's listening on the line, like John or others, who is a member of the community, what's the best way to kind of think about, how do I make my voice heard and create a space at the table to be able to be a part of these conversations that are happening? And I'll start with you, Jason.
Make sure I caught all of that. My speaker was breaking in and out.
Yeah.
Are you asking about establishing partnerships and how to begin those?
Specifically for folks who are just like, I'm just a community member, I live in the Bronx, this all sounds amazing.
Yeah.
How do I think about this? Should I be talking to my doctor? Should I be emailing you? Like, what is the kind of way that we get kind of the ordinary voices? Because even folks who are parts of CBOs and FBOs, there's a certain level of privilege and access that brings. So what about folks who are just experiencing these conditions, who live near the Cross Bronx and say, I want to be a part of this conversation? How do we think about that level of engagement?
You asked the $1 million question, Dr. Sappho. That's something that we kind of mull over on a regular basis, try to figure out the best way to reach those people who aren't connected to the organizations, because you're absolutely right. The average person in these communities is not a member of a community group and may not necessarily have access to us in that manner. We certainly encourage any and everyone throughout the Bronx to contact us for any reason, and we're happy to help however we can. A lot of times, though, we find people kind of stumble upon us because they're looking for the Department of Health for some other reason. People often associate the Department of Health with restaurant inspections, or there are other things that the Department of Health is responsible for. And they'll come across our phone number or our building and come into our office to try to get one of those things addressed. And it's in that moment where we're able to tell them who we are, what we're about, and how we can help them individually for other things that will be beneficial to them and their families. I guess it's kind of beneficial for us to have that broad association with the Department of Health, but we really rely primarily on those partnerships with clinical organizations, community-based organizations, and as much as we can do in terms of promoting our services out in the broader community, we do. We have a team of community health workers that we get out on the ground, doing canvassing, reaching out to local businesses along major commercial corridors throughout the Bronx. Whenever we can, we have folks flyering out at train stations or high foot traffic areas just to let people know that we're in the community and we're available to them. And whatever you can do to help us spread that message, we definitely appreciate it.
Awesome. And Rishi, from your experience with various groups, any additions to that?
Yeah, many groups are looking to be able to think about how to offer services to healthcare. And when it comes to healthcare kind of engagements, three things that we say is one, don't Don't forget to ask about money to cover your indirect costs and your startup costs. Second, don't accept fee for service when everybody in healthcare is moving towards value. Make sure that you get paid for that you look at models to be able to get paid for the full costs of caring for folks and providing services rather than just accept a fee for service model. We don't want to reinvent the fee for service juggernaut in social services that healthcare is clearly kind of done in healthcare itself. We don't want that. So don't accept fee for service. And the third is demand value of investments rather than ROI kind of assessments. So that's a big part of what happens. A lot of CBOs are engaging in conversations with healthcare, oftentimes around services, and end up having to feel like they are both ill-equipped to understand the healthcare kind of business and how to intersect in partnerships. We say that we recognize that the playing field is uneven between CBOs and healthcare, and therefore there's a need to be able to recognize that power imbalance and be able to state what you need, go make sure you're explicit about that, and then finally to the Not 62 kind of coalition and other kind of models, find power in partnerships. So look at fiscal intermediaries, look at backbone organizations, and look at coalitions to be able to kind of put yourself on more of a level playing field to be able to negotiate both around services as well as advocacy, if that's the goal as well. Because healthcare is not incentivized or built for true partnership with communities. If anything, the economic kind of model of healthcare has borne out the fact that we have been extractive rather than generative far too often. And so we need to make sure that we don't put CBOs into a position of having to accept an extractive model. We need to flip it.
Thank you for saying it. I think it's often not said enough. And so that acknowledgement, I think, is important because many of us that are sitting in this room are sitting from the healthcare perspective and have that framework and that kind of power dynamic. I want to thank both of you for your time, for the provocativeness, I think, of some of what you've offered, for also just some of the revisiting of information. You know, when you asked, like, are we familiar with this? And there were all those threes. And Jason, you asked it as well, and folks are kind of familiar, just revisiting what we know, but also what we can push forward even more. I want to thank those who joined us, and please feel free. Both of our speakers have shared their information. I don't think that they're joking when they say that you can reach out and you can follow up, certainly with them or their teams. And so please feel free to do so. Our next rounds will be September 26th. You will get a follow-up email that'll have all the links that Jessica pulls together so that you can, you know, do more work and do more reading and do more thinking about these issues if that's of interest to you. And we always ask for your feedback. We can always think about, you know, bringing people on that you recommended. And so we really take that feedback to heart. And so we share the survey with you, and we will fill it when you have a moment. I want to thank everyone. Thank you for being here. Thank you so much to Jason and Rishi, to Dr. Manchanda. Thank you to their teams for making this work happen. And thank you to all of you for sharing this space with us. And that is it for today. See y'all later. See y'all in September.
Thank you so much.